Welcome, everyone. Welcome, parents. We are the Bright Family Engagement Team, and we're a little shorthanded tonight, but Victor and I will run the show tonight. We're welcoming you all to our January topic for the month, which is parenting your child who has self-harming behavior with Hannah Karpman. As a reminder, the Bright Family Engagement Team provides and offers support to family engagement for the year. It is totally free, available for all parents, K through 12, anywhere in the country. Each month kicks off with an educational topic, just like we have here tonight. This is our topic for the month. And then over the next 3 weeks, we have parent support groups. For the second Tuesday of the month, we have an elementary-based support group. The third Tuesday of the month, we have a middle and secondary support group for parents. And then finally, the fourth Tuesday of the month, we have a BIPOC affinity group. It's a great opportunity to connect with other parents, people that are going through some of the same things you are. As we know, parenting is a journey. It is something that needs to be done in community. So I'm going to pass this over to my colleague, Victor, so that he can introduce our guest for the evening. Thank you.
Thanks, Julie.
Thank you, Julie. I am so thrilled to have Dr. Hannah Karpman with us tonight for this really important topic. Parenting your child who has self-harming behaviors. This is not a pleasant topic, but it's an important topic to talk about. And I feel like this is sort of like a secret thing, and people don't want to talk about it. People don't want to ask questions. So I'm so excited to have Dr. Hannah Karpman with us tonight. She has an MSW and PhD and is an assistant professor at both the School for Social Work at Smith College and UMass Medical School Department of Psychiatry. Thank you so much for being here tonight, and we're looking forward to your presentation.
Thanks so much for having me. And I really appreciate the opportunity to talk to parents. I am, as you said, currently a professor at Chan Medical School at the Shriver Center. But prior to that, I was a child and family clinician and worked in community-based acute treatment settings. And I'm also a parent myself, which I think is important as we come to this topic, and a parent of 2 children, one of whom has had some significant needs in a variety of ways. So while I am not in your shoes and can't understand exactly what parents may be going through, because we all have different circumstances, it certainly has shifted the way that I think about the young people that I work with. So today I'm going to talk a little bit about self-harm behaviors in young people, and wanted to start with just an introduction and a welcome, and to recognize how many demands parents have on their time right now, and what it means to find the time you did to be here tonight or be watching this video, and really appreciate that. The other thing that I wanted to mention is that I will present a lot of statistics and existing research literature on this topic tonight, and that literature is limited by the language that those researchers use. So, for example, we know that young people who are gender nonconforming experience higher rates of suicidality, suicidal ideation, but the literature on self-harm hasn't quite caught up to the ways that we're thinking about gender. So I will use the language from studies, but want to recognize that some of that language isn't the language I would prefer to be using. So I'm going to start with an overview of self-harm, what we know about it, how to identify it or things that parents could be looking for, and then a discussion of the risks and some ideas about, as a parent, how you could respond to a young person in your family or your care who's engaging in self-harm behaviors. So this definition comes from the National Institute for Healthcare Excellence, which is the governing body that issues what are arguably the best clinical treatment guidelines for young people who are self-harming. So they define self-harm as intentional self-poisoning or injury, irrespective of the apparent purpose. And that doesn't include repetitive and what they called stereotypical behaviors, such as headbanging. And I think what they're saying here is that there's a host of repetitive behaviors that we tend to think of as being present in young people with neurodevelopmental disorders of some kind, And those can include things like head banging or repetitive hand motions. And that's not what we're talking about here. What we're talking about is behavior that causes physical harm that's done with sort of the conscious decision to engage in that behavior rather than sort of a repetitive body movement that may be out of the control of the young person. And the most common forms of self-harm that we see are cutting, piercing, hitting, burning, and picking. Other kinds of self-harm that are pretty frequent are young people who do something to prevent a wound from healing. So, for example, they may experience a natural injury and then continue to sort of pick at that wound to keep it from healing. So that would be another behavior I would add to this list. And some of these behaviors appear to be more frequent in certain sectors of populations of young people than others. So, for example, in kids that are assigned female at birth, we tend to see cutting as the predominant form of behavior, whereas things like hitting and picking tend to be seen in more frequently in children who are assigned male at birth. So I think the first question that lots of parents have is, how would I know, right, if this was something that is happening with my child? And so I include this picture here because I think parents often don't know what cutting looks like, or we have this idea that cutting means there are open gaping wounds that require stitches, and that will automatically result in an emergency room visit. And often cutting can be very easily hidden, or cuts are very thin. So you're seeing here the arm of a patient who's now an adult, and those are scars that had healed. But the point that I like to make here is that frequent sites of cutting are places that you might not see on a regular basis. So it's more likely on the inside of an arm than an outside of an arm, on an inside of a thigh, but places that clothing can easily hide. And also that the lines, not always, but often tend to be thin if we're talking about cutting. The other things that you could think about paying particular attention to are young people who have unexplained wounds or bruises. So there was a young woman that I worked with for several years who had cigarette burns on her wrists and arms, and would tell her parents and people around her that she'd been smoking, or somebody had been smoking and dropped a cigarette on her. But it became clear that those burns were more than sort of accidental. The other things that we could look for or might notice are blood stains on clothing or bedding. Lots of young people tend to cut either in their bedrooms or engage in self-harm either in their bedrooms or in the bathroom. So you may see blood on bathroom products like towels. If there's a young person who's talking frequently about having accidents, so I offered that cigarette burning example, or a young person who frequently has bruises in a particular part of their body that don't seem to have an explanation that makes sense. And the other thing that we often encourage parents to pay attention to is finding sharp objects that you might not necessarily expect to be in a young person's bedroom. And in particular, we think about things like razor blades here, but sometimes that's also piercing materials or tattooing materials or the tools associated with those. And finally, something that for me in the years that I worked clinically was often an early sign was a young person wearing clothing that wasn't weather congruent. So somebody wearing long sleeves in the middle of the summer, or insisting on wearing pants when the day before they were in shorts or a swimsuit, so that it appeared that they were trying to cover something up. Now, for those of us with teenagers, sometimes that's something like a tattoo or a piercing and may not be related to self-injury, but it can be a clue that there is something that the young person's trying to hide. And finally, the thing that I like to highlight is one of the things we know from the research literature, and I know from clinical experiences, often kids who cut tend to be those who withdraw and disengage. So isolation, withdrawal, and not wanting to come out of a bedroom, not wanting to be with friends that previously they've spent time with, might also be warning signs that might encourage us to look for other things. Now, also, those are warning signs of depression, so hard to know. And here are just some statistics that I think are helpful for framing the issue. So rates of lifetime self-harm behavior have increased over time. So when I was practicing 10 years ago, the predominant measure said that about 15% of young people had engaged in self-harm behavior at some point across their lifetime. Now, some studies have those estimates as high as 30 to 50%. And across all the studies, we know that those rates seem to be increasing over time. Here's that language piece that I wanted to highlight. So the literature says females are twice as likely as males to engage in the behavior. And what they're talking about there is how young people are identifying on the survey. So it would be however that young person answered a binary gender category on the survey. The age of onset averages around 12, but increases as young people age. And I'll talk about this in a minute, but there's some hypotheses that the onset of cutting might have something to do, at least in some segment of the population, with the onset of puberty, whether that be something related to hormones or changes in the body, or for some young people, it might be related to distress that the physical changes in their body related to puberty cause. And I think this statistic is really important and something I'm going to talk more about later. But those who do seek help, and we're not talking about the parents, we're talking about the kids here, are most likely to seek help from peers. And why I think that is important is because often when a young person is struggling, some of the quickest consequences that we go to as parents are removing kids from their peer group. Limiting their ability to go to parties or spend time with their friends or participate in extracurricular activities. And what we know from the literature is that these kids in particular seem to go first to their peers and often get quite a lot of help from them. So we may want to think about that intervention differently. And then the last thing I really want to talk about is the relationship between suicide and self-harm. So suicide is currently the second leading cause of, sorry, that should be death, not deals, in adolescents in North America. And young people who do self-harm are at increased risk for completed suicide. And in fact, the strongest predictor of future self-harm, serious self-harm, both fatal and non-fatal, is previous self-harm. So I say that because self-harm and suicide are not the same thing, but there is a relationship between the two, which means that we need to take the behavior very seriously. So here's how I understand these statistics, both as a parent and as a clinician. The first thing that I want to say, particularly to the parents in the room who might be having recently found out that this is something going on with a young person in their household, is that self-harm is not entirely uncommon. I think that it might be something we don't talk about very often or enough. But again, if we think about that lifetime prevalence of 30 to 50% of young people, you are not alone and neither is your child. And I think that that's a really important thing, both for parents to hear and for young people to hear. They're not the only ones struggling with this. Second is that girls, and I would add to this list based on my reading of the research literature, young people who identify as trans, gender nonconforming, are at higher risk than cisgender boys to engage in that behavior. There is some debate about where trans youth fall in this spectrum, but I would say in general, that tends to be, we do see a gender distribution. Self-harm behavior is a clear indicator of increased risk, so should be taken seriously. And the other piece that I like to stress here that these statistics leave for me is something's going on in our social context for young people. Life is feeling harder. If young people are resorting to self-harm as a way to manage feelings,
Oops, I think we lost Hannah.
Do you guys have me back now?
Yep, you're back.
Okay, I'm not sure what happened there. I
I'm not
apologize.
Welcome back.
froze. Let's try it again.
Okay, I'm not sure what happened there. Um, okay, so
So sorry about that.
no, it might be on my end, so I apologize. So I was just saying that there's something going on in our social context or in our world that is making life harder for young people to live in this country and more stressful. And that we're increasingly seeing people turn those feelings, those young people turn those feelings inward to themselves. Um, the last 2 points are that puberty might be related somehow, and is a particular time for parents to be paying attention or looking for this behavior if they're worried. And the last one, which I mentioned before, is that peers are an important source of social support. So this is the piece I really wanted to highlight. So self-injury does not necessarily indicate that someone is suicidal. In fact, most of the young people that I've worked with who were really seriously engaged in cutting didn't have suicidal ideation. So they would, for example, talk about feeling unhappy or intense feelings of distress or sometimes feelings of being numb, but they didn't endorse wanting to end their lives or having an intention to do so. That said, there is a higher risk for young people who engage in self-injury of suicide. And some of that is that depression is a risk for suicidality. So it could be that self-harm is indicating to us that there's underlying depression or anxiety that gets worse over time. But the second piece, and this is an important piece, is that sometimes the intention isn't suicide, but if you're cutting or engaging in a self-harm behavior that is high risk, it can accidentally result in mortality. So that's something to be considering as we think about a young person's risk. So there are lots of reasons that young people engage in self-harm. The number one reason, and I will say that in clinical practice, this was my experience, is that there is some distressing thought or feeling that teenager is struggling with and that they don't know how to solve or how to cope with or how to escape. Escape is the word I heard a lot from some of the young people that I worked with, and that there's something about the self-inflicted pain that provides a sense of relief from that feeling or thought. So in that way, we could think about cutting as a coping mechanism. And a colleague of mine used to really make the point, and I take this point seriously, that cutting is a very effective coping mechanism for lots of kids. So if we're asking them to stop doing that coping mechanism, we want to be thinking about what are we helping them do instead, because it is serving a purpose for them. The second reason that the literature points to, and so these are in order of frequently endorsed, how often people endorse these ideas, is to punish themselves. So I will say that I've seen personally this more in populations of young people who are struggling with body image or gender dysphoria, that there's sort of a way that thinking that their body isn't right in some kind of way encourages them to sort of do something to that body as a way of punishing themselves for something they feel is wrong. The third one is complicated because we hear a lot of, oh, this kid's just doing that to get attention. And in fact, that is a reason that young people engage in self-harm. Now, we want to think about why would somebody go to the extreme of hurting themselves to get someone's attention, and that there needs to be a pretty substantial level of pain or suffering in order for someone to result to that kind of behavior. So that doesn't mean that if a young person says, oh, I was doing it to get attention, that we should dismiss or ignore the behavior. What it means is we should get really curious about what it is that's going on for them that requires help or attention from an adult in their lives. There is a subset of young people who are actively thinking about suicide, and that self-harm can be a precursor to that. And then the last one that I mentioned earlier, and again, this was something I saw a lot in the clinical population that I worked with, all of whom were self-identified as girls, was to feel something. So I worked with a lot of trauma survivors, and often those trauma survivors had sort of numbed themselves psychologically to feelings as a way of coping with whatever had happened in their lives. And creating physical pain was a way to kind of check back into the world, to kind of get rid of that numbing. So that's what folks are talking about here. So I want to respond to this, your kid is just seeking attention piece, because I think it's something we hear a lot with regard to self-harm, but also I think it's something we've heard about kids with mental health struggles for decades. And I hope that our field is really moving away from pathologizing kids and young people and their behaviors to understanding what I like to say, which is that behavior is a language of need. So if we can think about behavior as another way of communicating a need or a desire, instead of being something that our job is to squash in some kind of way. So on one side, we have the stigma and the implication of this, right? Your kid is just seeking attention. And there are some implications here, like there's a right way and a wrong way to ask for help. And I feel like if a kid is doing anything that's coming to our attention as a help-seeking behavior, that to me indicates that they're willing to seek help. So I really try to see that as a positive thing, not a negative thing. There's also the assumption here that that self-harm behavior isn't dangerous, and in fact it is and can be, and it's an important behavior that for us to pay attention to and to be actively engaged in sort of risk assessment around. There's also some assumptions here about, young people shouldn't need help or attention when they're in pain, that, there's sort of that suck it up and deal attitude that sometimes we hear, and I think discussions about building grit and building resilience in some ways have made this worse rather than better. If a young person's engaged in self-harm, they do need our help and attention. And there is a level of pain that's there that requires empathy and support. The other implication here is that ignoring the behavior is going to solve it. We know pretty conclusively that that's not the case. And last, that a young person, and I hear this all the time, you're not making good choices. Why aren't you making good choices? And I have a hard time imagining a young person making a choice. So if we think about all of the negative consequences that come with cutting, your parents surveilling you all the time, people talking about you, you having to hide your arms and legs, maybe having to go to the emergency room. I have a hard time imagining that a young person would actively make that choice if they had other coping skills they could use that would result in more positive feedback. So if we think about kind of being the star of the baseball team versus being a kid that cuts, sometimes we equate any kind of attention as being positive attention for young people. And, I can assure you, having worked with them and been one myself, that's not all attention is equal. And, kids who get a lot of negative attention might be used to that as a way of getting attention, but that doesn't mean it's a positive experience for them. So the reality here is that seeking help, regardless of how someone does it, is an indicator of need for help. And that self-harm is a really clear signal that there's some kind of intense distress going on for this young person, regardless of what the reason is. So if the reason is to check in and reduce numbing, if the reason is to reduce or manage a feeling, if the reason is to get attention, all of those reasons are really about a level of distress that's intolerable. Coping with the underlying issue that's causing self-harm requires empathy and support and skill building. Those are the interventions that we know are helpful to young people and adults who self-injure. And the last thing I want to highlight here is I think self-harm can make adults feel really out of control. Why can't I do something about this? If I could just get every sharp object out of my house, then I would be able to prevent this. So your kid is just seeking attention, I think sometimes is a way of adults defending or dealing with this idea that they feel out of control. So if I just blame it and make it a bad thing, then, it helps me deal with how I'm feeling. So that's my response to your kid is just seeking attention. So here's some myths and facts about self-harm, and we've gone through most of these, but I think it's important to have them on hand. And often I coach parents to use them. If someone says to you, your kid is just doing that to seek attention, or they're just being manipulative, is something I often hear. Self-harm's a coping mechanism for pain or distress. It's not just young people that engage in self-harm. In fact, we know that often people who engage in that behavior as a young person will engage in it again at some point in life, including in adulthood, that can be relapsing and remitting, kind of come back and forth. That in other cases, it's a temporary response to a situation. So it could be that there's an environmental stressor, it's a coping skill that a young person tries out, then it disappears and we don't see it again. So there isn't one pattern that we always see with self-harm. And the last point that I want to really kind of highlight here is that compassionate and non-judgmental discussions about self-harm therapy and medications are the most supportive ways of engaging. And I'll talk more about these myths in a minute, because I'm going to talk about what you can do at home. So Victor and Julie, how are we doing so far, both on time and content? Okay, great. So what do I do? So NICE, which I talked about earlier, has sort of what at least the research literature and clinical literature says are the best guidelines for treatment for self-harm. So the first thing is to seek a full psychosocial assessment at the point of medical attention. So if you just notice that this is happening and you've taken your young person to the emergency room, or somebody else did, I would really encourage you not to let them leave the emergency room until a psychosocial assessment's done. So that often means meeting with a social worker or psychiatrist. And that person should, they're not going to do a full battery of testing or that kind of stuff, but they should at least get a sense of what's going on with this young person. What are the strengths and challenges that they're facing? What's their understanding of why the behavior is happening? And what do they know about the family and support system, both in terms of what's stressful, but also in terms of what can be helpful. Maybe there's an aunt or uncle that they feel particularly close to, or a neighbor, or the person who lives downstairs who could be a social support if they don't feel like they can talk with their parents for whatever reason. So really getting a full picture of what's going on and why this is happening. And the research literature actually shows that traditional risk assessment scales, like those 10-point question scales, are not good indicators for self-harm. So really pushing, if you're the parent and working with a PCP or an emergency setting, really pushing them to do a thorough psychosocial assessment. The second thing is to schedule regular appointments with a primary care doctor, and you may have to push your primary care doctor in order to do this. And the reason that NICE recommends this, and also frankly I do with parents, is you don't want to be the cutting police. So let your primary care doc take that role. They can do checks, 3 or 4 times a year. If you're worried about the severity of the behavior and it causing real injury, they're the best person to be making that assessment, not you. And you don't want to be in that control battle with your young person and their privacy about their body. So let the PCP take that role. The best practices in terms of therapy are cognitive behavior therapy or dialectical behavior therapy. Those are the 2 therapeutic approaches that have the best known response rates or improvement for self-harm, with a minimum of 4 sessions, and that you want to access those as soon as possible post the first initial injury that you notice. Now, that's in a dream world. We all know that there are waiting lists for therapy and for psychiatry for kids all over this country right now. So I'll talk in a few minutes about some strategies for managing that. Some young people also might benefit from medication, particularly if depression or anxiety is part of the picture, but really engaging a full team to understand what's happening is your goal here. The other thing, and this is a little bit controversial in the literature, but I'm going to say what I think, which is that I think we should always be thinking about harm reduction strategies. So if we have a young person who we know is cutting and is going to cut, having a conversation with them about how to make sure things are sterile, how to know if a wound is too deep and they need to get attention from someone, how to bandage and care for those wounds. If a young person is engaging in self-tattooing, kind of understanding what the risks of disease transmission can be and how to eliminate those. So if someone's going to cut or engage in self-harm, how to do it in a way that minimizes potential unintentional consequences, I guess is the way that I would frame that. Primary care docs and the nurses in those offices are often really good for these kinds of conversations, but you may have to specifically tell them that you'd like them to have one. And the last point here is that risk assessment should be complex and not just rely on a 10-point scale or a very brief conversation. And we all know that the children's behavioral health system is at best underwater right now. But our role as parents is often to be the advocates. And if we think people are understanding something too simply or they're missing something that's really important, this requires the role of a parent as an advocate to really say, you only talk to them for 5 minutes. And self-injury can really be a risk of suicide. I'm going to ask that you do a little bit more thorough of an assessment here, or questioning the physician or the social worker. Why do you think this is low risk? Why are you recommending this treatment? What's your rationale? To really encourage them to think complexly about what's happening. And then the last point is to make a clear plan. And I talk about 2 different kinds of plans, not just a safety plan, which for me is reactionary. So what do we do in the moment when there's a risk of cutting or a cut, but also a care plan? What's our long-term goal, intervention, team, not just how are we thinking about this in the moment when there's the crisis, but what's our plan overall and our goals overall, and who are the people that young person and those parents can turn to as they take this journey together. And I have a colleague who talks about therapy and mental health recovery if you think about a sitcom, there's each individual episode, but then there's the story arch over the season. And the safety plan is really how do you manage those episodes? And the care plan is what are you doing over the course of the season? Okay. So to go into that a bit more, a safety plan is a written prioritized list of coping strategies or sources of support that a young person can use. My favorite intervention is actually an art therapy intervention where I have kids draw a waterfall and then collage that waterfall. So as you're walking up that cliff to the edge of the waterfall, what are all the things that often happen? What are the thoughts you have? What are the feelings that you have? What might I, as someone who can see you but isn't you, notice? Right? So those are all the triggers and the warning signs. When you're at the top of that waterfall, what does that look like? And I'll have them collage that. And then, and that helps draw the safety plan. So we know what we're looking for, and we can talk about what are the interventions for each of those things. So if I'm withdrawing, what's the intervention for kind of pulling me back out or naming for me that I'm withdrawing? So I use that visual with young people a lot. And then the care plan is the plan of treatment or healthcare. And that is really about what are our long-term goals? How are we going to achieve them? How are we going to know we're making any movement here? And who are all the people who are going to be involved and committed to addressing whatever the need that this young person is expressing? Okay. So the last thing I want to talk about is actually talking to the young person. So when I worked at a suicide hotline early in my career, one of the things that one of the trainers said to me that I've always held is you're not going to put the idea of something in someone's head. So if you ask about, are you thinking about hurting yourself? Are you thinking about dying? Did you cut yourself? I think sometimes parents, and certainly I know in training clinicians, we worry if we mention it that we're creating the problem, and that's just not true. So you should feel free, comfortable, and I would encourage you to ask those questions and ask them directly. The kinds of questions that you can think about asking are things like, walk me through it. How does it feel before, during, after? That if we think about that waterfall analogy, and what that's doing is it's showing your child or teenager or young adult a willingness to really hear, that you're really interested in what that experience is like for them. Being open to the idea that it is an effective coping mechanism, albeit potentially a dangerous one. So what is it helping you with? Because then you can think about what's that need or that feeling that we need to help teach that young person how to cope with in a different way. Is there anything stressing you out right now? And how can I help you with that? What's it like for you to talk to me about this? And the key for any of these questions is that your job is to have the best poker face that you can as a parent when you get these answers, to nod, try to keep a neutral face, make eye contact, be calm and reassuring, and listen, listen, listen. And I will tell you, as a parent, that that is often the opposite of what my instinct is to do in those situations. I have been accused and like to give lots of unsolicited advice to my children and everyone else in my life. But really, if we think about cutting as a language, as a behavior, as a language of need, your job is to say, I see you asking for help and I want to help you. That's what you're trying to communicate. And the last thing is take your child seriously. So this is a behavior that is indicative of pretty serious pain, and we don't want to minimize it or ignore it. Parents often say, what can I do at home? And sometimes I hear things like, can I lock up all the sharps? Or what should I not have in my house? Or should they be grounded forever? Should they never get to see this boyfriend or girlfriend again? And sort of, 20 years ago, we would have said yes to all those things. Now we know not effective. So the first thing you can do, which is the most important, is model healthy ways of managing stress. And I think when we say that, sometimes parents think, well, I don't have outbursts. I don't scream and yell. And sometimes as parents, the opposite is true, especially for those of us who came from families where there was lots of screaming and yelling. Maybe we overcompensate and we just pretend like everything's okay all the time. That's not healthy either. So how do we model for our kids? I'm feeling really stressed today. I'm going to do this thing to cope. So my mother-in-law used to say, every night I take a bath, and this is my bath time and nobody interrupt me and this is my me time. But that's a good example of indicating to the rest of us that there was some kind of level of stress, that this was something that she did to manage that stress that was effective for her, and that it was okay to ask for it or expect it from everyone else in the family. Keep lines of communication open. Don't, if a kid is cutting or engaging in this kind of behavior, all of a sudden expect the world to stop. You want their day-to-day life to continue. So you should continue to expect them to contribute to family chores or responsibilities. There's also a sense of belonging that's generated from those kinds of activities or expectations. Stress and maintain family time. So I remember I said that isolation is a risk factor. So we want to really reduce isolation. And the way to do that is to encourage other kinds of engagement. So my own children call this FFF, forced family fun. And we joke about that in my house, but I'm serious about it. And that keeps me connected to them. It gives me time with them. It lets them know that I'm making that time that's protected for them, and it gets them out of their bedrooms and away from their screens. So forced family fun. We had what they call forced family athletic time last weekend when I made them all go skating with me, which they hated even more. Respect the development of your child's individuality. So some kids are quiet and shy. Some kids do need more time alone. Some kids aren't. So really letting them be who they are and positively reinforcing that. This is a big one, providing for firm guidelines around technology usage. So we know there's a relationship between social media use and a wide variety of behavioral health conditions. Increasingly, I'm encouraging parents to set really hard, firm limits around technology, both early and late. And one thing we can control often with our teenagers is whether that bill gets paid. So, we may not be able to install anything on their phone, but we sure can make sure it's on or off. And it's a scary thing to do, but sometimes we need to do it. We don't want to model family secrets or repression or mismanagement of emotion. So because self-injury is so stigmatized, if anything, I would sort of overcompensate for that with the child in my house. And in fact, with my own kids, we talk about behavioral health a lot. What is ADHD? Why do people have stigma about that? I often talk to my kids about how in the caveman ages, somebody with ADHD was probably the person who kept everyone else fed because they noticed the animal and jumped on it before anyone else even realized what was going on. So, having those ongoing conversations about behavioral health, about coping skills, and making it part of family language so that it's not something that we don't talk about. Avoid overscheduling or putting pressure on your child, especially if we think about trying to reduce the cutting behavior. So I said it's an effective coping mechanism. So if we're taking that coping mechanism away, it's not a good moment to put additional pressures on a young person. So we want to be giving them a chance to try new ways of doing things and not increase stress at the same time. And the last one is just model getting your own help and managing your own struggles. So what not to do? Don't yell, don't lecture, don't put them down, don't engage in harsh punishments. And I want to say, for any of you who've done all of this, 15 years ago, this is what we told parents to do, right? Consequence them, restrict them, isolate them. And now we know that that's not the only approach, and in fact, a pretty ineffective one. So, don't fault yourself if you've been on this list. And also, having a child who's self-injuring is really stressful. And we want to fix it as soon as possible. And if we think we have the solution, we're going to share that unsolicited advice. So, don't shame or criticize yourself if you've been here, but we do know that these aren't effective things. So threats, ultimatums, and then these are the two that I think are really sort of counterintuitive. One is don't go through your kid's room, read their journals, search their drawers. I think that especially parents who've had children who've been in inpatient settings where providers do those things, they think they should be doing them at home. Please don't do that, because it breaks down trust and makes your child less likely to seek help from you or tell you when something's really wrong. And in terms of the taking self-injury tools away, what I can tell you from the literature is that a young person who wants to harm themselves is going to harm themselves anyway. That I can tell you from running an inpatient unit, there is no way that you are going to find or even know everything in your household that they could use. So instead, I would work on communicating, talking, encouraging them to tell you if and when they're feeling like harming, being willing to be with them or do something else for distraction in those moments, and not spend a lot of time trying to control what you can't, even though we wish we could. Okay. And then the last thing I'm going to say, this is my favorite phrase from DBT and other kinds of therapy, is the both and conundrum, that something can be both true and there can be a caveat. So, we feel powerless as parents, but we are powerful beyond measure. And especially when we're parenting teenagers and young people, we can feel like, oh, there's nothing we can do about this. And I use the cell phone as an example. Like, I can't control it. They're going to be mad. They're going to explode. Sure. But you can shut that phone down if you're managing the bill. So, there's that. But the other piece of that is that we are teaching our kids by our own actions all the time, and not by what we say, but what we do. So there's this conundrum of like, is this my fault? And I think about this with my own kids, one of whom struggles with some of the same things that sometimes I struggle with. Like, is this my fault that I created? And the answer to that is, to some extent, yes, right? So my child might have a genetic predisposition or other things in their life that's going on, but also what I'm modeling in the ways that I'm living are what they learn. So sometimes the best way to manage that is say something like, gosh, mom really struggles with organization, and I know you do too. And we're both going to get help. And here's how we're going to do it. We're going to watch this TikTok. We're going to read this book chapter together. We're going to watch that tidying up TV show, which in my case only resulted in everything being dumped out of drawers on a bed that never got cleaned. So I don't recommend that intervention. But really modeling the idea that we all struggle and we all have strengths and weaknesses. Nobody's perfect. And we're going to work together to manage the things that are hard. I have seen really amazing work by parents who have had a child who self-harmed and seen it as a wake-up call about the ways that they're not managing their own emotions well, and let themselves learn through the things that their children are learning. And I always am learning from my kids, who are the first to tell me what I could be doing better. So that's what I call the both and of parenting. And then the last thing I want to say is tips for finding a therapist. And I have the hairdresser image on here really purposefully, which is that I say to parents and to kids all the time, that you should think about finding a therapist like finding a hairdresser. You might get one haircut and it doesn't suit you and you need a different one, or you might not like the way this hairdresser talks about cutting hair or what their philosophy is. They may not understand your type of hair or your hair needs. And two things. One, it's okay to see the Supercuts hairdresser because they have an appointment until you can find the hairdresser that you really like. So no therapist has to be a permanent therapist, and sometimes we take what's available because it's available. That's okay, but don't stop looking for the really good fit. And the second is to say to young people, like, I have, especially when there weren't wait lists, it's harder now, said to young people, like, I'm going to require you to see three, and then you pick from those three. You might not want to go, but this is the way I can give you control. I can't say you can't go, but I can set up 3 appointments for you and you can see all three and then you can pick among them. So really encouraging in the ways that you can a young person to have as much control. The last thing I want to say is there actually are some really great online CBT programs. Harvard has a couple of them that are running clinical trials right now. There are some, I'd have to look for specific locations, but it's worth looking for online CBT or DBT if you can't find something that doesn't have a wait list in your area. And there are nonprofits that are doing that effectively. CBT in particular, some of the manualized treatments, you can get at least a base like 8 or 10 skill sessions, which is somewhere to start in the meantime. There are also some really good anxiety, depression, coping skill management apps, and online skill building sessions. I'm actually doing one with my child right now. We're doing it together, which is a good way of kind of showing that investment and maybe learning something too. And the last thing I would say is to feel free to be as assertive. I am a therapist, so I feel like I can critique us. I look at Psychology Today and everybody's a specialist in everything. And I encourage parents to question that. So you say you do CBT, tell me about your training. DBT has a certification. So are you actually certified in DBT? How often have you done it? It's okay to ask those questions and often good to do so. So that's what I have for everybody tonight. And I hope any or some of it was helpful. And I'm happy to take questions.
Wow. Thank you so much, Hannah. That was incredible and so helpful. I think hearing your view as a clinician and also as a parent has been so important to hear. And there are so many things that I didn't know and also things that I was afraid to even think about. And you made it very easy to listen to and also just take in. So thank you for that. Um, I do have a question, and
Yeah.
it's a social media question.
Mm.
So I have a preteen child, and already cutting has come into our lives through her friends and through social media. She came to me a while ago, just she saw something on YouTube, and then one of her friends actually got involved with cutting, and her mom initially went to social media to say that social media is the reason why it happened. And I'd love to hear you speak on that, like
Mm.
how much influence that is, how much you talked a little bit about how, it's genetic or, things can happen in children. But I'd love to hear your thinking around, like, is it contagious? Like,
Mm.
because the child saw it on the, now she's gonna go do it and all that. So thank
Yeah.
you.
I think the contagion factor is a really good question. And it's been probably the best studied around suicide. So we do know that often when there's a suicide in a school or an area, there are clusters. And there's lots of ideas about why that might happen, though I'm not sure we know the full solution. What I would say about cutting, and Julie and I were talking before this tonight, and somebody once said to me, "You're the average of the 3 closest people you know." And I love that analogy because I think it's true, right? So my 3 closest friends are the coping skills I have modeled for me. They're the ways of thinking and understanding the world that I have modeled for me. They are giving me the lens for how I think about problems or problem solving. They're often the mirror for what I understand about myself. So do who those 3 closest things are matter? Absolutely. And I think in particular with social media, if one of those closest things is a social media figure who's very charismatic, who the child idolizes, who maybe doesn't have the young person's best interest at heart. So I was listening to an NPR episode yesterday about how much money influencers are making off of child views. So if I'm motivated to get a kid to watch my video because every time they watch my video I make money, I'm not thinking necessarily about what's in the best interest of that child. So I do think peer groups and influences in general are really important. And I think one of the things that we've seen as kids are using screens more, often those three closest things, one of them might be an online personality and not someone we know or see in the daily life. So one thing I say to parents, and I try to do myself, though it's hard, is like, know what your kid's doing online. Hey, what are you looking at, honey? Can I look at it with you? Now, my daughter will be like, sure. I don't think that's going to last much longer, but I'm going to try. Knowing how to use the history on the browser setting time limits to things like YouTube. So at the very least, if my kid's on it for more than half an hour in my house, they have to come ask me for more time. So I might grant it, but at least I know what they've been on because I have a YouTube setting. I have an Alexa alert on my phone that tells me anytime my kid searches something on Alexa, what they're searching, which is funny sometimes, but also, the one time they were looking for pictures of boobies, it also alerted my phone. So I think knowledge is power in this case, is one thing. I think the other piece is educating kids about social media. So my kids will say things like, oh, content creators are trying to make money off of me. And that's because we talk about it at the dinner table. So I think there are some really great children's books now on sort of fake news, fake media, social media use. And those are good interventions too. Now, how much does social media matter? This is my personal belief. I don't ever think that anything is the result of one thing. I think it's always a confluence of factors. So I have a kid who I struggle to sometimes get off the online world and into the real world. And I think in her particular case, it's the combination of a complicated peer dynamic at school that makes being online easier. And who she is as a person and what she's engaged by and how easily that's available online. So I guess I would say it's complicated. I don't think it's ever just one thing. And I think it's great to blame social media, right? Because then we don't have to be
Of course,
responsible.
that's what people do. That was so helpful. Thank you so much.
Yeah,
Well,
well, ask me in 5 years when my kid's a bona fide teenager how helpful it was, and I'll tell you for real.
yeah. So Hannah, I shared with you before we got on that I work in a school, and oftentimes when I have a student that it's clear that they are cutting, and I talk with them about it. One of my jobs is to reach out to the parents. And I'm just curious if you had some guidance, one for schools, because I believe what I see in schools is, yes, there's a conversation and it's more of a safety plan rather than a care plan, but also oftentimes there was, and then this has happened recently with two sets of parents, is they tell me that their kid, kind of what you were saying, they're trying to get attention and they do this when they're in trouble at home. And I struggle to respond to that because then we're not actually, as you said, trying to figure out what they're communicating with us. So I'm curious if you have some really good guidance for schools, and then also those of us that are reaching out to families and maybe sharing that information with them.
Yeah, these are great questions. So let me think. So I think, gosh, the school question is tough because you're so limited by the resources that you have. I think my best advice is also the hardest advice, which is to think more complexly about it. If you have the extra 5 minutes, get more information to ask the question you might not have time to really hear the answer about, to take the time when that kid passes you in the hallway to sort of glance at their arms or legs or notice what they're wearing and whether it's weather congruent. And I think sometimes when, I certainly know this about myself when I worked in inpatient settings, we see cutting so often that it's easy to underestimate the risk of it because it seems so normative. But it is really an indicator of severe pain, and it's a risk factor of other kinds of things. So I guess I would say pay more attention to it than less. And in terms of the parents, you know, that line, yeah, it might be attention seeking, but behavior is the language of needs. I use that line a lot with parents.
Yeah.
And you know, sometimes I get, well, their need is to be grounded or to, you know, blah 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 blah. But you know, or I try to get curious. So they're attention seeking or they're trying to get out of something. Well, why do you think they want to get out of that thing so bad that it's worth cutting themselves? And I've asked parents that, and I can see the moment of like, oh, right, like, yeah, that is a little bit of an extreme behavior. And maybe if my kid is cutting themselves to go to the emergency room so they don't have to be in school, school is a really awful place for them to be. So let's try to understand why that is. I say the same thing about school refusal, right? Like, you know, why is school so awful? Why would a child want to avoid that so much? So what's the thing they're trying to avoid? Why do you imagine they're avoiding it? Um, and and then sometimes I say, well, what if it wasn't? Well, what if they weren't just doing it to, can you imagine if they weren't, why else they might? You know, what if the opposite, like, you know, what if the opposite were true? And then the last thing I say, which is a tough one, is like, well, what do you think your daughter, or what do you think your son, or what do you think your kiddo would say to me about it? Like, would they agree with that? Would they say something different? What do they say when you ask? Or where are you hearing that, right? So the other thing, like, sometimes it's not the parent's fault that they're thinking about it that way. Like, as I was saying, I was trained to think about it that way 15, 20 years ago. And if they're working with a provider who comes from a really behavior management kind of approach, or who hasn't read updated information about cutting, they may be getting that from a professional, or from a physician who doesn't have a lot of time and doesn't want to deal with it. Um, so sometimes it's just about providing education, like having an article printed out that you can give them, or encouraging them to look at the NICE guidelines. Cornell Medical School has a really good self-harm for parents brochure, that I would think about printing out and having available, you know, if you have the copy machine money at your school, which lots of schools don't have right now. So that, I don't know if any of that's helpful.
No, that is fantastic. I'm writing down, I'm taking notes as you say it. Well, we've actually come to the end of our hour, Hannah. I feel like we could keep going. I really appreciate how you shared that these behaviors are a way of communicating. I think that's a big takeaway tonight, and that these are coping skills. These are coping skills that kids are using or people are using, and that we need to teach new coping skills. And I can see myself as a parent in this, things that I didn't do right with my own children, and wished I had better modeling, and I'm figuring it out as I go. And I really agree with you when you say we learn from our kids, because we do. And I'm grateful for that. I do want to remind parents that we will be next Tuesday, we will have a parent supporting parents group. They are at 7 p.m., both East and West Coast. I have put those in the chat. There are different flyers for each, each coastline. And then the following Tuesday, we will be doing, so the next Tuesday is an elementary parent support group. The following Tuesday, the third Tuesday of the month, will be for middle and high parents. And then finally, our BIPOC affinity group is our fourth Tuesday of the month. If you have any questions, please reach out to us at Bright Family Engagement. I hope you have a great evening. Thank you so much, everyone.
Thank you, Hannah.
Thanks for having me.
Yeah.
Great.